All right, let's continue on our code here. You guys ready?
Okay.
Did it kick you out or are you still in the game? Still in? Here we go. It's okay. Okay, go for the pulse. Which side? Good. On the left side. Okay, pulse on the left side. That's my next question.
Oh, wait.
Yeah.
No, it's like, please don't.
Perfect. Okay, so it's on the left side, okay, and it's the fifth intercostal space. Okay, intercostal means between cartilage, it means between your rib cage, between your ribs is what it's saying. So if we go and we find the first one and we go below it, that's the first intercostal space, the first space in between cartilage, and then you go down until you find the fifth one. It's usually just below the nipple, right? At that mid-clavicular is the other anatomical landmark. So this is your clavicle, so the middle of it. Okay, so those are all the terms that we use to find our PMI, right? Our point of maximum impulse. And so that's what you need to know and verbalize for your lab checkoff when you do your apical. Okay, so that's the PMI, that's how we find it. Okay, you could, though, put your stethoscope on your patient in any number of places and hear a good apical. Okay, so that's just something that you should know in clinical as you're working with each other in lab. We look for the PMI, but you could, even on the right side, okay, you could hear a good apical and count it and get your appropriate number. Okay. Very hard. Okay, what causes tachycardia? So these were just some examples that you kind of read about. So what causes tachycardia? Well, what is tachycardia? Fast above 100, right? So heart rate above 100 is tachycardia. So what would cause that? Okay, so sometimes we can use the word hypo to kind of eliminate, not really in this case. Okay, so what's hypothyroidism? We've talked about a little bit here and there. Thyroid. So your thyroid is responsible for what process? It starts with an M. Metabolism. Okay, so your thyroid is responsible for your metabolism. Okay, so how you burn energy, how you function, if you're like energetic and fast, kind of strung out looking almost, or if you're kind of slower and more reserved, kind of taking your time with things. Those are the two extremes, okay, when you think about that as far as metabolism goes. Okay, so most people have normal metabolism. Your metabolism depends on what you eat and how active you are, period, okay? But otherwise, sometimes patients will have specific medical conditions that affect their metabolism. So if they have hypothyroidism, their metabolism is abnormally slow. They're sluggish, their digestion is slow, all of those things. So they would not have tachycardia, they would more likely have bradycardia. Okay, if they have hyperthyroidism, their metabolism is very fast, and so those are the ones would have tachycardia. Okay, so we saw hyperthyroidism. Okay, hypothermia, anybody choose that? A couple people chose that. Hypothermia, we talked about how fever, which is hyperthermia, causes tachycardia, but hypothermia is going to cause bradycardia. Okay, so everything is kind of slowing down, your pulse is going to slow down. So that's bradycardia. And then digoxin, You can kind of rule that out because you've never heard of it before. I wouldn't do that to you. But digoxin is a heart failure medication, and it causes bradycardia. So we give it to our patients who have high blood pressure, high tachycardia. We give them digoxin. It slows them down. But when we're giving our patients that, we have to worry about causing bradycardia. It's like an extreme side effect. Okay, so that leaves hypovolemia, and later on in the semester we'll talk about nutrition and fluid and electrolyte balance. So hypovolemia versus hypervolemia, if we have fluid overload versus fluid deficit. So hypovolemia is another way of saying dehydration. So if you've ever been like really sick and dehydrated, if you've ever been like really hungover or something, or if you've been like throwing up a lot, you probably felt your heart beating really fast, you weren't feeling very good. Okay, and it's because we've been talking about perfusion, and what our cardiovascular system does is it brings all of our cells energy and oxygen. Okay, so if we have hypovolemia, that means our volume is low. So no matter how much our heart is pumping, our volume through our body, we're low. We don't have enough, so we're not going to be getting the glucose and the oxygen and the things that we need as much because we just don't have it. We're dehydrated, we're hypovolemic. So our body says, maybe if I speed things up, I will be perfusing better. So it's like a defense mechanism when we're dehydrated, or if we're bleeding out or anything like that, and we're hypovolemic, our body knows that we're not getting perfused, so your body will kick up your heart rate to try to increase perfusion. Okay, so that's how those two kind of go together. And we'll talk more about that. Okay, the funny thing is, if you have hypervolemia, fluid overload, you also have tachycardia, but it's for a different reason. It's because you're overloaded and your body is working hard and it's trying to move that fluid through. Okay, so that's one of those tricky ones to kind of understand. But tachycardia we can see with hypo or hypervolemia, which is just fancy ways of saying either dehydrated or fluid overloaded. Okay, so which is not a manifestation of low cardiac output. Okay, we've talked about cardiac output some, decreased cardiac output, how it's a bad thing. It just means that your heart isn't functioning and pumping like it should. End result of that is we're not perfusing. Okay, so low cardiac output is a bad thing. So that would kind of help you in narrowing down your choices. You see 3 things that you don't want, 1 thing that would be a good thing, so that would be your choice, right? So which of the following is not a manifestation of low cardiac output? If we have low cardiac output, we're not perfusing, we're gonna be tired, we're gonna be dizzy, our blood pressure might be kind of low, okay? Our pulse ox will probably be low, right, not high, okay? High pulse ox is a sign of good cardiac output, adequate. That's just one of those negative questions that you'll see. Okay, which of the following causes a decreased respiratory rate, or bradypnea is the term for that. Like we just talked about, opioids or narcotics depress the respiratory system. So like if you go in the hospital and you log in the computer and you scan an opioid to give to your patient, the computer will make you put in your patient's current respiratory rate before it lets you give them that narcotic. It's a built-in safety factor because we know respiratory depression is a side effect of that. So if you're too busy or something's going on and you don't think, as a nurse, to check your patient's respiratory rate before you give them an opioid, your system should help remind you to keep the patient safe. Okay, all the rest of these will cause tachypnea or an increased respiratory rate, smoking, anxiety. And then albuterol is a medication that we'll talk about. It's a main inhaler that your patients take for trouble breathing, for constriction of their airway. It comes in an inhaler. It also comes in a nebulizer where they put the mask on and they put the liquid in the vial and it nebulizes and aerosolizes for 10, 15 minutes. It comes in those two different forms. So that is to help them breathe easier. A side effect of albuterol is tachypnea and tachycardia. So you'll go in and your patient will have just had a breathing treatment and they'll be like, I feel, really jittery. You say, yeah, that's because your breathing treatment that you just had. So give them some water, try to flush it out of their system, and just try to do some deep, slow breathing with them. Okay, so that albuterol will cause jitteriness. Another one of those negative questions, which would you not do? So there's going to be 3 things that are good that you would do and 1 that you wouldn't do, and then that's your choice. So when we're doing respirations, we don't tell them. We piggyback it on the radial or apical or whatever we're doing with them already, so that we can get an accurate number. Place them in patient semi-Fowlers. We might do it, we might not, but it's not something we would not do, right? That would be fine if they were in semi-Fowlers, that's fine. What is semi-Fowlers?
30 to 60.
Yeah, 30 to 60 or 45, right? So Fowlers is all the way up usually, so semi is kind of like halfway up, 45 degrees maybe, okay? And then watch the pattern before starting the official count, yes, because we never know what we're gonna be watching. Sometimes it's their belly, sometimes it's their shoulder, maybe there's a piece of paper sitting on their lap and you can easily see it move up and down. So we have to find our spot that we're gonna observe first. And then to count for 30 or 60 seconds would not be wrong. If we counted for only 30, what would we have to do with our number? Yeah, multiply by 2. Okay, and the respiratory rate is the most lied about vital sign because your machine doesn't do it for you. Okay, so don't forget, count your patient's respirations. Okay, good. It's that brachial artery, so that's the main one that we should use. That's our main focus for now. Just for your knowledge, we can do them on the lower arm, we can do them on the leg, but you'll talk more about that eventually. Okay, usually upper arm brachial artery is what we're looking for. You've made it to the yellow. So both choices. Okay, so hypotension is low blood pressure. Okay, so one of these things you're always going to think about and talk about till the end of time is change position slowly. Okay, we always want our patient to change position slowly. So we don't want them to get dizzy and fall down. Especially if they have any type of altered blood pressure, high, low, if they're on any type of medications. Now their normal built-in regulatory mechanisms are messed up, okay? So the vasoconstriction and dilation, doing that when it's supposed to be to maintain a normal blood pressure is all out of whack at this point. So at any time, their blood pressure could drop or go up. So we always wanna keep them safe and change positions slowly. Okay, and then if our blood pressure is too low, what our blood pressure is our fluid volume, right? So a main intervention is gonna be to increase our fluid volume. Orally if they can, or with IV fluid if they can't, or if it's too severe. so this is starting to get into fluid balance, which we're gonna talk about. But the main point about it is blood pressure. So we're talking about vitals, and we've talked about diuretics before. We've said that word before a little bit, and Lasix or furosemide is our main example that we've kind of talked about. And so what it does is it decreases your fluid volume, causing a decreased flow. Okay, so it makes you pee out excess fluid. So we'll talk more about that. If those other options don't really make a lot of sense to you yet, that's okay. Just as long as you know, or you will write it down and think about it and maybe know for your test, that a diuretic helps treat high blood pressure by making you pee out extra fluid. Okay, good. So high blood pressure has a systemic wide effect on your body. It changes your anatomy and leads you to be more susceptible to all kinds of chronic conditions. Okay, good. So those are some alternative scales that you'll see, but the 0 to 10 is our main focus. Be pretty good. Pain is whatever the patient experiencing it says it is. Okay, so it's subjective when we ask our patient about their pain. But okay, good. So it is subjective, but there is objective data that we can collect that correlates and matches if they're having pain or if they're not, right? So if they're sleeping and snoring, they're probably not really having pain, right? You go in and their respirations are 12 and their heart rate is 60 and they're just opening their eyes when you come in there and they're making a lot of, and you're making a lot of noise. And they say, oh, hey, my pain's 10 out of 10. Okay, does that make sense? Does that match up with your objective information? Okay, you're probably gonna ask some more questions. You're not just gonna say, okay, let me go get you 10 milligrams of Dilaudid. I'll be right back. I'll push it in fast. You'll feel great. You know, we have to kind of collect more information and make sure it all matches up. Okay, and then also that kind of helps us if you've ever experienced or been in a situation where the nurse is taking care of a pain-seeking patient, and you're trying to keep them safe, but you're trying to keep their pain under control. Having all these parameters and knowledge about vitals kind of gives us more, you know, confidence when we say, no, I can't go get that for you, and this is why. Because these are your respirations, this is your blood pressure, this is your pulse. I just had to wake you up. Okay, so pain is subjective. We want to believe our patient. We want to manage their pain. I want you to be more afraid of under-medicating your patient's pain than over-medicating, because honestly, in our situation, in our job, that's what happens more often, is we under-medicate our patient's pain rather than over-medicate it. But just knowing those vitals that kind of match up with it, and we need to keep them safe. And like I said, your systems, if you try to scan and give an opioid, it will make you put in and say that you assessed those numbers and you made sure and said it was okay, based on those vitals to give that drug. Okay, good. So non-pharmacologic means non-medicine, so you can rule out So changing position is a huge one. It's easy, it's often overlooked, okay? Like we talked about, our patients have decreased proprioception, impaired bed mobility. They can't move themselves, okay? They're limited, okay? But we know that they need to change position. Okay, so getting ahead of that, moving them, not leaving soiled dressings. We talk about dressings, that is referring to like bandages. Like if they have a wound or some type, that would be a dressing. Once it gets soiled, which means dirty or like full of drainage, it is very uncomfortable. So that'll cause some distress for them. So we wouldn't do that. Okay, so non-farm, all of those things, changing position, making sure they don't have like crumbs in their bed and their sheets aren't all old and nasty, making sure their room isn't gross and smelly, and all those things are non-pharmacological. Ice, heat, distraction is one, especially if you're taking care of pediatrics. Put on a movie they like. Okay, this is kind of giving you a head start of our getting into our GI and GU systems when we talk about elimination. So physiological effects of pain, so what's going on in the body, can include a GI ileus, so gastrointestinal ileus, and that just means a blockage. So like kind of constipation, things backing up and not moving. And then urinary retention is again kind of just like what it sounds like. So the bladder is full of urine, but it's not being eliminated. It's just sitting in there, you're retaining it. Okay, and so that's true. That can be a physiologic effect of our patient experiencing pain. Good job, Angie. What is it?
I have 2,400. 2,400 or 2,000?
Is it not 2,000?
Okay, so let's talk about this. This is kind of like an intro to medications a little bit and dosages. So a lot of our drugs come in milligrams, right? All of these are in milligrams. Our Tylenol comes in 325 milligrams. The extra strength are the 500 milligrams. It doesn't come in 100 or 1,000. And acetaminophen is over the counter. It's for pain. It's taken very commonly. It's also in lots of other medications, so like Dayquil and NyQuil and different cold medications. Okay, so it's very common. So it's important for us to know what the maximum daily dose would be, which is 4,000 milligrams. Sorry about that. Okay, 4,000 milligrams. Okay, so like if you take extra strength Tylenol, anybody take extra strength Tylenol for anything ever? Do you usually take one or do you take two? You take two of them, right? Because you're really hurting. Okay, so that's 1,000 milligrams, so that's one dose. Okay, so that would be 4 of those doses in one day. Now your liver is really having a hard time metabolizing that drug, and you can cause some harm to your liver. Okay, so it's 4,000 milligrams. Okay, that is something good to know because after non-pharmacological, Tylenol is our first line for pain medication. Okay, so we give Tylenol often. We give it a lot. Our patients take it a lot, so we need to know that max dose. Okay, you might see if your patient is on dialysis or has liver failure, their max dose is only 3,000 milligrams. It's a little bit lower. Okay, so sorry, I keep that in wrong. Okay, so just something to think about as we start thinking about dosage and medication. Okay, so this is just really hitting home to you the ABCs, okay, and to not leave your patient with abnormal respiratory rate, to not leave your patient with an abnormal pulse ox. Okay, if oxygen is a possible answer, that is your answer. Okay, if that is a possible issue with your patient, that is what you need to focus on. Okay, so life depends on oxygen. The rest of these things we can go without forever, or at least for a limited amount of time, much longer than oxygen, but we can't even go a minute without oxygen. but it is the blue one. Okay, it's the alveoli do not necessarily remove oxygen from the blood. The best answer is the blue one. Okay, so venous blood comes from our body, right? It enters our right atrium, right? It goes to our right ventricle, and then it goes to our lungs. Okay, so that blood that's going into our lungs, that's going into our alveoli, is used up blood. Okay, so in our alveoli, that used up blood, the carbon dioxide is going to cross over from the capillaries into the alveoli to be breathed out, and oxygen that we just breathed into that alveoli is going to cross over into our blood. Okay, so it's where oxygen and carbon dioxide change place in the alveoli. Okay, green is wrong because green is talking about perfusion. Okay, so what we're talking about here with the alveoli and the blue is oxygenation. Okay, so oxygenation has to happen first. Okay, so we have the blood from the right ventricle, it goes into our lungs. That's blood that's already been through our whole body. Okay, it's delivered the glucose and the oxygen. It's picked up the carbon dioxide, any type of waste just from our cells doing their normal thing. Okay, so it's used up blood. So oxygenation occurs first. They swap places. Okay, so the oxygen we just breathed in goes into our capillaries. The waste, the carbon dioxide, goes out into the alveoli. We breathe it out. Now that blood goes from our lungs to our left atria, okay, then to our left ventricle, then the rest of our body. Okay, so it's oxygenated. So now we're on to green. Now the exchange of oxygen and carbon dioxide between tissues and peripheral capillaries. Okay, so now your blood, your vascular system is going to carry all of that oxygenated, nutriated blood throughout your whole body, and it's going to cause that exchange. Okay, so that's why the green one is wrong. It's talking about what's happening in the rest of your body. Blue is first, that's the oxygenation. Questions on that? Good. So just hammering home, that rationale of what the pulse is doing, what the blood pressure is doing. Why do we need to know these numbers? What does it mean if they're abnormal? Okay, pretty good. I think it kind of stuck out. I said carbon dioxide a lot. That's our main waste product of oxidation, which is just our cells doing their thing, just being alive. Okay, it's carbon dioxide. That's our main waste product. Okay, pretty good. Ventilation is just breathing in and out. Ventilation or respiration, same thing, just breathing in and out. Okay, and then over here, that's oxygenation again. And then over here, that's perfusion again. if you remember the SA node or the sinoatrial node, so it's a pump, but it's controlled by an electrical system. The electrical system is controlled by your brain, right? Your brain determines what's going on and releases certain hormones to increase things or decrease things that control the electrical system, which controls the pump. Okay, you'll talk more about the electrical system as you progress through the program. In like third semester, I think you start looking at EKGs and telemetry and things. But just knowing that it's an electrical system will kind of help you as we start to talk about fluids and electrolytes. How if our fluids and electrolytes are off, we see the changes in our cardiac function, okay, because it's an electrical system also, right? And all of the sodium and potassium in our body have electrical charges. So if we have too much or too little, it's gonna affect how our electrical system, our heart is pumping. Just kind of something to think about. Okay, so your heart is a pump that sends blood throughout your whole body, but it's a muscle, right? It needs to be perfused itself. So surrounding your heart are little coronary arteries, right? So they take your heart muscles, oxygen and glucose and all those things, and they carry waste away. So those can only fill up when your heart is relaxed. So it pumps, those can't fill up. When it relaxes, that's when they fill. Okay, so if the heart rate is going way too fast, there's no time for those coronary arteries to fill up. So now the heart is having even more damage because it's not getting oxygen. Okay, so that's what you see when your patient's having a heart attack. It's those coronary arteries, those little arteries that are surrounding and feeding the heart muscle itself. Those are blocked, and that is what is causing a heart attack. Okay, so once those arteries are blocked, just like in our brain when we were talking about, whatever part of that heart was supposed to be perfused by that coronary artery that's blocked, now it's not getting oxygen, it's not getting nutrients, it's gonna start dying, it's not gonna work anymore. So then you see the cardiomegaly, which is the enlarged heart muscle. It's not a good enlargement, it's bad, it's not healthy or active heart tissue. And you start to see the heart failure. All right. Amy, Krista, and Abby, good job. So don't forget to get something on your way out. Lots of good stuff. All right, we got a little bit more time. I think we have enough time for at least one more activity here. Go in here. Alright, if you want to follow along, I'm going to go into a video case study. Okay, and there's going to be some little scenarios like yesterday and then questions in between that I'll have you guys answer. Okay, and then this one has a little quiz at the end also. So this will probably take us to the end. Next week, we're gonna continue on. I've got a lot more vital signs activities that we're gonna do. Got like a little scenario, and you guys will go through that clinical judgment measurement model, so you'll recognize cues, analyze, prioritize your hypothesis, and all of that. I've got like a case study for you guys to do, and then we'll get into head-to-toe assessment. Same thing, we'll have a Kahoot and a bunch of activities. Okay, so your ticket to class for Tuesday now is your head-to-toe assessment video. Okay, so again, the sooner you can get those to me, the better, so I can get them all looked at by the time class starts. So this one though, you have a little bit more responsibility. After you complete it, you are supposed to watch it, and you are supposed to identify what you missed. Okay, you have your check off in front of you, or you can get to it, so you know what you're supposed to do for your head-to-toe assessment. Okay, so, and I'm fine with you having like off to the side somewhere, some notes for yourself. I don't care, that's fine. If that is like what's hindering you, like you think you have to have it totally memorized, have some notes off to the side to remind you what to do, that's fine. Okay, it's just about going through it, doing all of those steps, getting that done. Okay, and then you're gonna watch your video and you're gonna see, hopefully you missed, I can't remember what the instructions say, lesson 3 or something like that. Okay, so if you watch your video and you see I clearly missed more than half of this, you should redo your video without waiting for me to watch it. Okay, you should know, really botched that, good thing I watched it, now I know and I can do it again, okay? It's for you, it's to help you, okay? So make sure you take your time on it. So that's the ticket to class for Tuesday, and then Wednesday, what's the ticket to class for Wednesday? Documentation, okay, so you have readings out of ATI over documentation. And then, what's the ticket to class for the following Tuesday? Oh, I have to make it still, okay? Then your last ticket to class before exam 2, you'll have some kind of activity in EHR tutor. I have to go in and figure out exactly what that will be. Okay, and then we'll be wrapping up. Remember, everything moved back a day. So instead of our exam 2 being on that Tuesday, like it says on the calendar, and then a day off Wednesday, that's not true. That Tuesday, we'll still be finishing up content because everything got moved back a day. Wednesday is that exam. There is no day off that week, right?
So will the exam be like last time where we come and do the exam and then have a break and then start next step?
Yeah.
Okay.
Yeah, so we'll have the exam that Wednesday, take a break, and then have class. I'm not sure exactly what we'll do, something. All right. Hey, while I'm getting into this, anything else, any questions? Everybody doing okay? You ready for clinical tomorrow, Friday, Saturday? If you're having any issues or concerns with your clinical, please don't hesitate to reach out to me and let me know. All right, we're gonna do gas exchange, oxygenation, oxygen delivery systems. All right, so that's the most important thing. If you know nothing else, I want you to identify if your patient needs oxygen. So we'll start with this.
Oxygen therapy is a common treatment that is used in a variety of settings and for many conditions, such as pneumonia, emphysema, and COPD, all of which can cause impaired gas exchange and result in hypoxia if not treated. When your patient requires oxygen therapy, it is your responsibility to make sure that it is initiated immediately and that the oxygen is administered by the correct flow rate and with the appropriate equipment. Because oxygen has the potential for dangerous side effects, it should always be considered a drug, and the rights of medication administration follow when initiating and managing patients receiving oxygen therapy.
Can we get some help, please?
Hi. What's going on tonight?
She can't.
Man, let me just have to sit back in the chair. How long's this been going on? I'm gonna get you right back to your room, and I'd like you to answer some questions at registration. Thanks.
Okay, so he's working
Carrie, I'm
in
just
the
gonna get you
emergency
hooked up to our
department.
pulse
She just
oximeter.
walked in.
Check your blood oxygen saturation. Gonna help us determine how much oxygen you need to be on. And I'm also gonna take your blood pressure.
Okay, so we got her checked in, he got her in a gown, got her in bed, and now he's getting vitals.
I'll just have you relax that down at your side. Looks like your oxygen saturation's at 88% right now, so I'm gonna put you on a nasal cannula with some oxygen at about 3 liters a minute. And this will just go in your nose.
nasal cannula. If they're not doing okay on room air, that's usually the first step then, is a nasal cannula. And he said he was gonna put her on 3 liters. So it is an order, it is a medication. So they're in the emergency department though. So they have standing orders, you know, if this is what your patient presents with, this is what you do, because if not, you know, how would they treat people? It's an emergency department. Okay, same thing for us up on the floor, on our med surg floor. Even if our patient doesn't have a standing order for oxygen, most all patients have a PRN order based on their vitals. So if they're desatting, which means they're below 92 or whatever it might be based on your facility, you can go ahead and put that oxygen on. You wouldn't have to stop and call the doctor. It's just kind of part of our parameters and nursing judgment. Okay. We talked about the pathophysiology of inspiration and expiration and how these processes provide the body with oxygen. That was the ventilation, oxygenation, and perfusion that we talked about. And then this video is just gonna kind of summarize
When you
that.
take a breath,
visually.
air sets off on a path to get to your lungs. First it enters your nose, nasopharynx, and oropharynx, and travels through your trachea. Once it reaches the bronchioles, the air splits to tunnel down both tubes all the way to the alveoli sacs. You can see all the small blood vessels called capillaries attached to these sacs, which is where gas exchange occurs in the lungs. When a person inhales, air rushes into the lungs and the chest increases in size. This is called inspiration. During inspiration, oxygen breathed into the lungs, diffuses into the capillaries, and circulates throughout the body via the circulatory system. When a person exhales, the chest decreases in size as gas forces out of the lungs, along with the carbon dioxide that diffuses out of the capillaries around the alveoli. Here is what the entire process sounds like.
Okay, so for head to toe assessment, when we do our lung sounds, you can do, you know, a ladder pattern on the front, usually start at the top, one side or the other, and kind of go across all the way down, and then you go to the back and do the same thing. You would do as many sites as you can. It just depends on your patient. I think for your checkoff, it says like 8 front and 8 back, so you'll look at that in the coming weeks. But it just depends on your patient, because a lot of them, they're there because they have respiratory issues, and as we do those deep breaths in and out, they start to get dizzy. So it just depends on our patient. Sometimes we can't sit there and do 20 lung sounds in and out all in one sitting. We have to kind of give them a break for that. But that's the sound that we're listening for. That would be normal lung sounds. That's what we call clear. Okay, so as you're listening and you're putting your stethoscope on them, you're avoiding bone, so all of the ribs in the front and your scapula in the back. We can't put it on bone because then we won't hear anything. Okay, so if we're not on bone, we hear breathe in and out, and it should be nice and clear. Okay, and that's normal. Other alterations that you're gonna see, the most common one is diminished, and that just means you kind of don't hear anything, and it's either because they have chronic changes and they're just not having that good oxygenation. Other times you'll see it with like severely obese patients, and it's just because of the adipose tissue, you can't hear that air moving in and out. So that's diminished. And then the other 2 common ones that you're gonna learn about are crackles and wheezes. So crackles are like our heart failure patient, or if they have pneumonia and it's fluid in their lungs. So it's like a bubbling, crackling sound. And then wheezing is like our COPD or asthma, and it's constriction. So it's just like what you would think like a wheezing sound, and it's a narrowed airway, so that air isn't moving very well. So those are the main sounds that you'll hear and that we'll listen for. All right, this part's done. Let me go back to the quiz. Just a couple questions here, and then we'll be done. All right, if you've got your markers and care of a patient, they need oxygen therapy. Oh, we didn't go there. But it was in some of your readings. The nurse should identify that which of the following types of oxygen delivery systems can deliver the highest concentration. You might remember this. And this isn't like something that you would have to remember for your test. This is just to start to expose you to the different types of oxygen delivery systems. Okay, and I'm just gonna continue. Oh, incorrect.
Oh.
All right, I just wanted to show you the types here. I just want to show you all the types. All right, so and in one of your labs, they'll have all of these out for you and start to see them. But I just wanted to kind of expose you to what you might see. Okay, so a simple face mask is just like what it sounds like. It's just a plastic mask that's gonna go on, and it can deliver a little higher than a nasal cannula, and those two little prongs going in your nose. So it's more for higher flow. A non-rebreather is a special type of mask that usually has a bag at the end of it, and again, it's for high flow oxygen. Okay, so our nursing home patients are like med-surg, stable patients. We're not gonna see really anything more than a nasal cannula, but just to start to introduce you to some of this terminology. And then an oxygen conserving cannula, I haven't even seen these in the clinical unit, but it's just a special type of cannula that can concentrate oxygen at a higher rate than a regular nasal cannula. So we'll have to see this clinical if we see any of those. And then a Venturi mask is a mask that's got like a tube at the end where respiratory can specifically dial certain concentrations of oxygen. Okay, so just different type of masks that you might see. Okay, this question hopefully is a little more specific. Yep. A nurse is planning care for a client who requires an exact concentration of oxygen. Which of the following oxygen systems should we use? Okay, and again, just do your best with this. More about with like the pediatric patients who can't sit and use a device, so they're kind of like a hooded area. Right, you're in a long-term care facility, you're planning care for a patient that's gonna get oxygen at 4 liters a minute with a nasal cannula. What intervention would you include? And again, this is more of a learning things question than a testing you on these questions, okay?
What if they can, doesn't say that
It was just the wording.
that's what's.
So, this first one is just, this one's just kind of silly, a woolen blanket in the hospital. It just talks about static electricity, and we just have to be worried about the risk of fire when our patients are using oxygen. So that's kind of a silly one. This one, if you chose this one, you were probably thinking about the bubbler, which it kind of explains under it. So it's just the wording. Again, that's not a very good test question. But if your patient is on oxygen for an extended amount of time, you might see a little plastic container of liquid hooked up to their oxygen, and that's a bubbler. It's for humidification. It's to prevent them from drying out. Okay, so just the wording was kind of funny. It says irrigation solution. That's why I didn't like that. Okay, and then cleansing the client's nasal cannula every 4 hours with alcohol. No, because that's gonna dry out their mucous membranes, which is why we're using that humidification, because we dry them out from all that oxygen. So the focus here was just saying that they're at risk for being dried out, so we wanna make sure we offer oral care for them. So that was the main focus of that. Okay, two more. Where patients 1 hour post-op, they had a cholecystectomy, so their gallbladder out with anesthesia. We should monitor for which of the following signs of an indication of hypoxia. Okay, so this one's a little more our speed. Okay, so what matches up with hypoxia? Yep. Hypoxia, so we said that's not enough oxygen. And then next week, when we talk about head to toe assessment, we're gonna talk about different colors of the skin. And it should just be nice, normal for ethnicity. It shouldn't be red or yellow or blue, could mean they're not getting enough oxygen. Okay, blue is cyanotic. Okay, so cyanotic mucous membranes means blue mucous membranes, so they're not getting enough oxygen. And then what's our last question? I don't even like this question. I'm gonna skip this question.
What's the answer?
I don't know. It's Greco.
What is the last one?
Brewy. Brewy isn't a lump sound. Brewy, you might have it in your head to toe assessment reading. Brewy is if your patient has a fistula for dialysis. So if they have dialysis and they have like a big lumpy bump in their arm, that's a fistula. And to assess for it, we feel it and we listen to it with our stethoscope. And the brewy is the sound that we hear to make sure it's still open and it's still functioning. That's what it sounds like. Okay. All right. That was something. All right, don't forget to get your prizes if you won. Let me know if you guys need anything or have any questions. I'm gonna turn this off. I'll take your name tags and your markers and your erasers.